Okay, let's continue having silly fun. Again, you should stop the video and try it on your own first. I'm going to do the same 3 steps. 1, 2, 3. 1, 2, 3. Every single time. Question number 1. What is the osis? I look at pH and it's low, so I have an acidosis. I then go over and look at that bicarb. It's 27. That's elevated. So I have an acidosis with too much base. That means I have a respiratory acidosis. Question number 3. Did they just get it or have they had it a while? Acute 1 to 0.1, chronic 1 to 0.4. All right, CO2 is up 20. 20 times 0.1 is 2. So if it's an acute, it's going to be up from 24 by 2. So I'm looking for a bicarb of 26 if it's acute. If it's chronic, 20 times 0.4 is 8. 8 plus 24 is 32. I look at the patient. They have a bicarb of 27. That's almost right on top of my acute bicarb prediction. So correct answer is an acute respiratory acidosis. What would this look like on a Davenport? Well, we would just move right along the respiratory buffer line. We haven't moved off of it. So this is an acute or uncompensated respiratory acidosis. Next, again, stop the video. I'm moving forward. Here we go. 1, 2, 3. 1, 2, 3. What is the osis? I look at pH. It's 7.55. That's an alkalosis. I then look at the bicarb. It's 37. It's elevated. Alkalosis, too much base, means metabolic. Did I get a respiratory response? Well, I don't even have to do a calculation. I showed you Summers' equation, which is what you would apply here, but I don't need to. Because bicarb went up and CO2 went down, I know I have a mixed disturbance. I've already defined a metabolic alkalosis, so it's a combined metabolic and respiratory alkalosis. Didn't even have to do a calculation. I know you're sad. I know you want to do the calculation, but here we didn't even have to. If you want to calculate it, you could. 13 times 0.7 is about roughly 9. So 9 plus 40 is 49. So I'm looking for a CO2 between 47 and 51. My number is about 49, and I give it 2 on either side. And as you can see, the patient has a CO2 of 37. That's well below what is calculated. But I didn't even have to do that. CO2 and bicarb went in opposite directions. I'm done. Yeah, this is metabolic and respiratory alkalosis. Because remember, second question already defined the metabolic alkalosis. What does the previous patient look like on a Davenport? Well, we have a metabolic alkalosis. We should go this way. CO2 should go up. But in the patient in the previous question, it went down. So we have a mixed metabolic and respiratory alkalosis. Next question, again, you should stop the video and try it on your own. Question number 1, what is the osis? I look at pH 7.37. That's normal range. Wow, okay. Which side is it on? It's just a little bit on the acidic side. So let's call it an acidosis, even though it's in the normal range, because they do have an acid-base disturbance. I look at bicarb and it's elevated. So pH is on the low side. Bicarb's elevated. This patient has a respiratory acidosis. Okay, have they had it a while? Or did they just get it? Is it acute or chronic? Well, CO2 is up 10. So bicarb's only going to go up 1. It'll be 25 if they just got it. But this patient has 29. The chronic bicarb is 28. 10 times 0.4 is 4. 24 plus 4 is 28. That's my predicted chronic. The patient has 29. So this patient has a chronic respiratory acidosis. Now I threw this one in to reiterate a couple of points. Number 1, pH can be in the normal range and you still have an acid-base disturbance. I don't know how many questions on step 1 will show up like this. Maybe none, but it's an important thing to remember. Second, big point on this. This is a classic COPD patient's blood gas. Okay, pH in the normal range, but on the low side, markedly elevated bicarb and CO2 because they have a kidney kicking in. They have a chronic respiratory acidosis, but the kidney has kicked in and increased that bicarbonate pool. So those concepts are very high yield for step 1. What does the previous COPD patient look like on a Davenport? Well, we went in this direction, so it was a respiratory acidosis, but the bicarbonate pool was markedly elevated, so this is a chronic or compensated respiratory acidosis. All right, last one for silly fun. Here we go. Again, please stop the video and try it on your own. But you'll see this is a lot more complicated one, and it's so easy and fun because we do 1, 2, 3. 1, 2, 3. All right, question number 1. What is the osis? I look at that pH. It's low, so they have an acidosis. I look at that bicarb. Have an acidosis with low bicarb, low base. Makes sense? It's metabolic. Now I have to determine, was there an appropriate respiratory response? I calculate what CO2 should be using Winter's equation. CO2 should be, bicarb is 12 in the patient. 12 times 1.5 is 18, plus 8 is 26. That gives me a range of, and I'll take 2 either side, so the range is 24 to 28. Patient is 25, so I know this is a metabolic acidosis with a respiratory compensation. And I now see, item 3, 4, and 5 are all acidoses with respiratory compensation. How am I going to differentiate this? Diarrhea, lactic acidosis, diabetic. Oh, anion gap. Don't forget to calculate the anion gap. Sodium's 138, chloride 90, bicarb 12. 90 plus 12 is 102. 138 minus the sum of chloride and bicarb, that's anion gap. 138 minus 102 is 36. So this is a mud pile. That eliminates diarrhea, but it doesn't eliminate lactic acidosis and diabetic ketoacidosis. How am I going to separate the, I look at that glucose, it's only 100. Well, then this is a lactic acidosis with respiratory compensation. This is not a diabetic ketoacidosis with a glucose of 100. All right, silly fun. 1, 2, 3. Silly, silly, silly fun. All right, a quick summary. Things that can cause a respiratory acidosis. Well, respiratory center depression with anesthetics, drugs, morphine, etc. Pulmonary edema if I can't breathe well. Cardiac arrest, any kind of airway obstruction. If I paralyze muscles, well, that makes sense. Now I can't breathe. Sleep apnea, I stop breathing while I'm sleeping. As we already indicated, chronic obstructive lung disease, COPD patients, or chronic respiratory acidosis, or classic respiratory acidosis. If I start to have problems with the muscular system, like with MS or muscular dystrophy, you have to remember all muscles responsible for moving air are skeletal muscle. And there is an obesity hypoventilation syndrome. I mean, an increase in CO2, that is hypoventilation. Now, for a metabolic acidosis, the cause can be narrowed down with that anion gap. Mud piles if elevated, hard up if gap is normal. All right, how do we get a metabolic acidosis? We gain acid. We could eat it or drink it, or the body can generate it, or the kidney just can't get rid of it, like in kidney failure. Or we could lose bicarb with carbonic anhydrase inhibitors, RTA, proximal RTA, diarrhea. Notice that all of those ones where we lose bicarb are hard up. That's a normal anion gap. Whereas when we gain a fixed acid, then that's a mud pile. Remember, CO2 should go down in a metabolic acidosis. And we can calculate what CO2 should be to determine if there was adequate or appropriate compensation by the patient. This is very, very important from a clinical perspective. It'll apply to step 1 as well, no doubt about it, but it's huge, very, very important from a clinical perspective. For a respiratory alkalosis, that just means we're breathing too much. You could be anxious, you could have a fever, that would also drive up ventilation. If you're hypoxemic for whatever reason, say like in high altitude causes hypoxemia. Notice high altitude is the last bullet point. Sometimes hypotension, pneumothoraxes, can cause a marked increase in breathing, and as a result, you get a respiratory alkalosis. And of course, VQ mismatch. In VQ mismatch, low VQ units can cause hypoxemia and you can hyperventilate. Or with a pulmonary embolism, we create a lot of dead space. Dead space is going to blow off CO2. Bottom line is you have a reduction in arterial CO2. And the decrease in CO2 means a decrease in bicarb. We calculate that bicarb for respiratory disturbances. See if the kidneys have kicked in. For a metabolic alkalosis, vomiting. Hey, we get rid of hydrogen. Think vomit. Don't vomit, but think it. Also, suctioning of the stomach, gastric suctioning. Loop and thiazide diuretics can tend to cause metabolic alkalosis. Some other kidney disorders, Barter's, Gittleman's, and Little's syndrome. We can get transcellular shifts, so hypokalemia will tend to cause a metabolic alkalosis, can tend to cause an alkalosis. Remember, hypokalemia and alkalosis tend to go together. Hyperkalemia and acidosis tend to go together. That's not 100%, but that's the tendency. Too much aldo, hyperaldosteronism, which is similar to Barter's, Gittleman's, and Little's. Too much aldo. Aldo causes potassium loss, and so hyperaldosterone could cause a potassium loss. Also, aldose stimulates hydrogen secretion. So you get a hypokalemia with hyperaldosterone. You'll also drive out hydrogen from the body, and as a result, you will get a hypokalemia and elevated pH. And don't forget the idea of a contraction alkalosis. It's where we lose extracellular volume without losing strictly bicarb. Remember, the kidneys reabsorb under normal circumstances all the filtered bicarb. So if I reduce extracellular volume significantly, kidneys are hanging on to the bicarb. The concentration of bicarb goes up because I've lost, effectively, water. Because the concentration of bicarb went up, you get what's called a contraction alkalosis. And in the kidney section, we discussed the idea of what maintains that contraction alkalosis, and that's the effect of angiotensin II on the kidney. All right, so metabolic alkalosis, we've lost hydrogen or gained bicarb, pH goes up, bicarb goes up. Makes sense. And Summers tells us how much PCO2 is going to go up. That tells us how much PCO2 is going to go up. All right, that's it for Silly Fun, Acid Base. It is silly fun diagnosing acid base from ABGs. I hope you're having silly fun, and I hope you have silly fun for the rest of your career.